All right, everybody, welcome back to another episode here of Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a good day. We've had a really busy kind of clinical month in terms of sick patients and lots of them and all that jazz. So lots of kind of intellectually stimulating cases, although that certainly means people are sick, which is never a good thing. You know, we had a kind of an interesting case If I could just take a quick 60 seconds of your time, I wanted to introduce our newest Whiteboard Medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. A middle to elderly age female. She came in short of breath, febrile, hypoxemic, chest x-ray showed bilateral interstitial opacities, most concerning for pneumonia given her clinical history, but other things can't rule out inflammation, can't rule out edema, all that jazz. She certainly wasn't fluid overloaded. Her bedside ultrasound had preserved biventricular function, so certainly didn't seem to be pulmonary edema. Couldn't necessarily rule out an inflammatory condition, but at the time, took a stand and started treating for pneumonia. And then interestingly enough, her urine Legionella was negative, but then the Legionella from her BAL ended up being positive. So a sick Legionella pneumonia. She ended up developing ARDS, severe, had to be prone, deep sedation, all that stuff. So quite sick. But those urine Legionella test sensitivity and specificity for any test is not 100%. So it's always a good reminder, right? If you have a high pretest probability for Legionella, those urine Legionella tests only test for several, and granted the most common, but several serotypes of Legionella. So they don't cover every serotype of Legionella, and if your pretest probability is high enough, even if the urine Legionella is negative, there's an argument there that maybe you should continue treatment with zithromycin rather than stopping it early or switching to doxycycline or what have you. So classic case of Legionella pneumonia, unfortunately complicated by severe ARDS. But anyway, not the topic for today. Today we're going to be talking about spontaneous breathing trials, a cornerstone of all intensive care units and kind of critical care medicine. So today in this video, or podcast if you're listening to it online. We keep forgetting we have a podcast, but it's very exciting. Check it out. In this episode, we're going to talk about what spontaneous breathing trials are in terms of goal, timing, duration. We're going to talk about how to do them, and we'll talk about a couple different methods, including TPs trials, pressure support trials, CPAP trials. We'll talk about a couple of the studies around that. We'll then go into how to tell if a patient is doing well on their spontaneous breathing trial. We'll mention the RSBI, and again, talk a little bit about some trials around the RSBI. Then we'll get into key considerations. We'll have a comparison table for TPs trials versus pressure support trials for CPAP trials. And at the end, we'll go over a couple practice questions. So stick around for all those. We would love to see you out till the end. And no further ado, spontaneous breathing trials. So what are spontaneous breathing trials? Well, a spontaneous breathing trial, as many of us know, is kind of the gold standard bedside assessment tool to determine whether a patient can safely be liberated from mechanical ventilation, right? So it's an evaluation on the patient's ability to breathe without significant ventilatory support, right? A way to simulate extubated conditions as a way to know or understand if a patient might be ready to be liberated from mechanical ventilation. So the goal here is we're trying to identify the readiness for extubation. A really important thing. Obviously, you don't want to leave anybody on the ventilator longer than you have to. There's certainly complications that can come with being on mechanical ventilation, ranging from just ventilator-associated lung injury to ventilator-associated pneumonia, sedation, delirium, all that stuff. So getting patients liberated from mechanical ventilation is critically important, one of kind of the cornerstones of critical care medicine. So the goal is to identify who's ready to come off the vent. Timing for spontaneous breathing trials, in general, and we'll dive more into the details on this, but in general, we're usually doing this after improvement in the underlying illness, right? What caused them to be intubated, and have we improved that enough to no longer need the ventilator, right? If the cause was that they were completely obtunded and unresponsive, are they awake now? If the cause was they had profound hypoxemia from pneumonia, is their pneumonia improving? right? All these things make sense. So have we addressed the underlying cause in a way in which we think they might not need mechanical ventilation anymore? Hemodynamic stability is another one. There's lots of gray to hemodynamic stability. The old adage used to be that you need to be totally stable, off vasopressors, the whole gambit. Now we're starting to understand that, you probably don't have to be totally off vasopressors. How much vasopressors are reasonable to come off the vent? Still an unanswered question. But some degree of hemodynamic stability, or maybe the more appropriate way to contextualize it, would be hemodynamic improvement. If you were on 30 micrograms per minute of norepinephrine and vasopressin, and that vasopressin's now off and your norepinephrine's down to, 5 or 8 micrograms per minute, maybe that's a patient who, even though they're still on vasopressors, you could consider liberating from the ventilator. This is not medical advice, never is. You should certainly verify all this before acting on it. We have disclaimers in the episode description and at the end of the episode, but anecdotally, our practice pattern, we're okay liberating patients from mechanical ventilation who are still on vasopressors, assuming we're improving their underlying illness. And then the last thing is adequate oxygenation and ventilation, obviously. So, I think many people, and we'll go into this more, many people would put a PEEP of less than 10 and an FiO2 of less than 60% as kind of two oxygenation goals before you can put someone on a spontaneous breathing trial. Some people are more particular, right? Some people talk about a PEEP of less than 8 and FiO2 of 40%. Some people maybe are a little more aggressive. Anecdotally, again, we use this PEEP less than 10, FiO2 less than 60% personally. And then typical duration of these spontaneous breathing trials, 30 to 120 minutes is probably reasonable. Some of the trials used 30 minutes before they extubated patients. Other people use a little bit of longer time frames. So 30 to 120 minutes, again, lots of gray here, which is good. That's why we're doing this video, so you can kind of hear a little bit of insight and practice patterns on that. So how do we actually do the spontaneous breathing trial? Well, it'd be easy if there's just one way to do it, but there's not. So the first thing when you're talking about it is, do they meet some of those prerequisites we mentioned, right? FiO2 less than 60%, PEEP less than 10, depending on who you are. Might vary per patient, but are they oxygenating well enough without significant ventilator support? Are they ventilating, right? Are they not hypercapnic? Do they not have acute hypercapnia where they're able to ventilate well enough on their own? Do they have some degree of hemodynamic stability or hemodynamic improvement? Do they have an adequate mental status? Can they protect their airway? If you were to extubate them, are they able to protect their airway? Do they have a cough? Are they awake enough to spontaneously ventilate on their own? Are they strong enough to do that? These are some of the soft indicators that someone is ready to come off the vent, potentially. And then the last thing is secretions, or can they manage their own secretions? And this is tough because a lot of times we're like, oh, they have significant secretions. What do you do with that? Gosh, we don't know what to do with that. If they have a strong cough, hopefully they can mobilize those secretions on their own. If they have a weak cough and lots of secretions, maybe that's someone you give a little more time on the vent. Tough to say, but secretions is something that you should at least evaluate for and think about before you liberate someone from mechanical ventilation. And then the other thing, like anticipated procedures, are they going to the operating room in 5 hours? If so, maybe you leave them on the ventilator. Do they need a MRI of their brain and a whole spine in 2 hours? That's a long test. Maybe leave them on the ventilator. So just kind of anticipated clinical course is another thing to think about. So if you've decided that, yes, they meet the prerequisites and yes, you want to do a spontaneous breathing trial, well, what the heck do you do then? What are the different methods to do a spontaneous breathing trial? We're going to talk about the two less common methods, and then we'll talk about the more common mainstream method. The two less common methods are a T-piece trial and a CPAP trial. And I want to be very specific with the verbiage here, because at times people call a pressure support trial a CPAP trial, and that's not necessarily true, and we'll get into that more. But starting with the T-piece trial, this used to be much more mainstream. We personally don't really do T-piece trials. We've maybe done it once or twice for kind of weird, unique situations. But in general, we don't do T-piece trials. And what a T-piece trial is you literally take someone off of the ventilator and you let them breathe through their endotracheal tube just hooked up to supplemental oxygen. There's no ventilator assistance at all. There's no PEEP. There's no inspiratory pressure. There's nothing. They're breathing through the endotracheal tube hooked up to wall oxygen. And there's some trial data to suggest that this isn't necessarily the best modality to use for a spontaneous breathing trial. In fact, outcomes were worse. And again, we'll talk about that trial in a second. But it makes sense that outcomes might be worse, right? Because you essentially have a straw, aka the endotracheal tube, going into someone's airway, and you're taking away all support and just having that patient try to breathe through that straw. So they don't have any PEEP, which means they can get alveolar collapse and atelectasis. Right? You don't have any inspiratory pressure. That inspiratory pressure, the pressure that is delivered during a breath, kind of gets over the resistance of the endotracheal tube. Try just breathing through a straw. That's hard, right? Now imagine being on a ventilator, being taken off that ventilator and being asked to breathe through that straw. So TPEs trials are not mainstream anymore, and for good reason, which we'll talk about. The other one we wanted to talk about that isn't commonly used is an actual CPAP trial. And we sometimes call pressure support trials CPAP trials, but an actual CPAP trial is that you just leave the patient on PEEP, but you take away all inspiratory pressure. So what this means is, the patient's still on a PEEP of 5, but otherwise they're just breathing through the endotracheal tube themselves. There's no inspiratory assistance. So you still run into the resistance of that endotracheal tube because every time the patient takes a breath, they have to suck air through that endotracheal tube without any assistance. There's still increased airway, there's still increased resistance trying to suck air through that endotracheal tube. And as a comparison to help that make sense, that gets into the more common approach to vent liberation and spontaneous breathing trials, which is a pressure support trial using pressure support ventilation. And what this is the most common way we do spontaneous breathing trials in the ICU, pressure support trials. And we essentially leave the ventilator providing a PEEP, just like it would for the CPAP trial, right? A positive end expiratory pressure. And usually that's minimal. Usually that's 5. But again, some people talk about less than 10. Some people talk about less than 8. But 5 would be minimal. We leave a little bit of PEEP. And then we actually provide some pressure support, some inspiratory pressure support, anywhere in the realm of 5 to 8 above the PEEP. 5 being minimal, 8 being a little bit higher. But anything greater than 8 is a little more significant in terms of support, which I'll talk more about in a minute. But just to lay this out, so what happens is the patient's on the vent. You switch the mode of the ventilator to pressure support. And that ventilator does not deliver any breaths except when the patient triggers it. So if the patient doesn't take any breaths on their own, the vent doesn't give them any breaths. They're completely apneic until you eventually get to the apnea alarm, in which case the ventilator then has a backup mode that kicks in. But when the patient goes to take a breath, the ventilator senses that and it delivers a certain amount of inspiratory pressure, that pressure support, 5 millimeters of mercury, 7 millimeters of mercury, some type of inspiratory pressure. And the thought there is it's just enough inspiratory pressure to get over the resistance of the endotracheal tube. So it's not intended to provide actual inspiratory support. It's just intended to provide enough pressure to get past that resistance of the endotracheal tube. And then obviously you leave some PEEP on like we talked about. And that is the most common way we do spontaneous breathing trials, this pressure support trial. And as you can see then, the difference between the pressure support trial and a CPAP trial is the CPAP trial just has PEEP. It doesn't have any of that inspiratory support. And a TPEs trial doesn't have PEEP or inspiratory support. You're just trying to suck air through that ET tube. So if we go into one of the trials that looked at pressure support trials versus TPEs trials, it's a trial by Thille et al., 2016, published in JAMA. And it was a multi-center RCT, had about 1,000 patients in it. And they compared pressure support ventilation, where you have that inspiratory pressure and a PEEP, right? Just enough inspiratory pressure to get over the resistance of the endotracheal tube, somewhere around 5 to 8 centimeters of water, millimeters of mercury, and minimal PEEP, somewhere between 5 and 8, just to prevent atelectasis, versus a TPEs trial. Remember we said TPEs trial means you just take them off the ventilator and attach their ET tube to supplemental oxygen. And what they found in this was that pressure support trials were associated with lower extubation failure rates than the TPEs trial, especially in high-risk patients, older folks, COPD, cardiac disease. And that's really interesting, right? Because it's saying that in patients you did the TPEs trial on, you were more likely to have extubation failure. And you start to wonder, is that because you took away the PEEP and everything, and that patient got atelectasis and lobar collapse and all that jazz, and then you extubated them, and they had more trouble remaining extubated? Then the pressure support trial, where you have some inspiratory pressure and some PEEP still there to maintain recruitment, get over that endotracheal tube resistance. So from this trial, it supported the use of pressure support trials rather than TPEs trials as the most physiologically relevant, patient-friendly SBT method, which is why not many people do TPEs trials anymore. All right, so going into pressure support trials, since that's kind of the main way in which we try to do spontaneous breathing trials, this is the most common modern approach. And as we talked about, the endotracheal tube adds resistance when you try to breathe through it. So a small amount of inspiratory pressure helps overcome that resistance, which is actually more similar to kind of that normal physiologic airway after you extubate them, right? When you extubate them, you're not giving them a straw to breathe through, you're just letting them breathe normally. And a pressure support trial mimics that extubated state better. Typical settings, as we talked about, is an inspiratory pressure, also known as a pressure support of 5 to 8, and a PEEP of, somewhere around 5, although some people would say less than 10, some people would say less than 8, and an FiO2 of less than 60%, although again, some people would say less than 50, or even 40 or less. So some variability in the PEEP and FiO2, but do note that this pressure support, this inspiratory pressure of 5 to 8 centimeters, if you start to increase that inspiratory pressure higher than that, you're no longer just overcoming the resistance of the endotracheal tube. You're actually providing them with significant inspiratory pressure support. And that's almost like pressure control. The pressure control mode of ventilation, where you're providing an inspiratory pressure to the patient to help them breathe. So you really want to make sure this pressure support is minimal. If you're starting to get a pressure support at 10 or 12 or 14, that is essentially pressure control. Obviously, you are still in a pressure support mode, but the amount of inspiratory pressure you're providing is significant. That is not mimicking, just enough inspiratory pressure to get over the resistance of the endotracheal tube. That's significant support. So this minimal pressure support number of 5 to 8 inspiratory pressure, 5 to 8 millimeters of mercury, is critical when you're doing these pressure support trials. All right, how to tell if a patient is doing well? Well, the first thing you should look at is the vital signs, right? Have they gotten super tachycardic all of a sudden because they're an extremis, heart rate of 120, 140? Obviously, they're not doing well then. Have they gotten hypotensive or hypertensive? Also maybe an indication that they're having trouble. Now, it's tough, right? Is it because of the wean and sedation? Is it because they're uncomfortable on the ventilator? All these things play a role, but vital sign derangements do imply that patients are much higher risk once you extubate them. Can they still oxygenate, right? Are they maintaining their SpO2 above 90? If you send a gas, a P to F ratio greater than 200, but really the message here is, are they still able to oxygenate while on a pressure support trial on the vent? Because if they're getting hypoxemic, that might indicate they're not ready to be liberated from the ventilator. Same thing with ventilation. Are they still able to ventilate adequately? They're not getting more hypercapnic. Some people routinely send gases when patients are on pressure support trials. We don't tend to do that unless we have something we're worried about. Sometimes we'll leave them on end tidal and make sure there isn't some big jump in their end tidal CO2 on the monitor, but obviously user preference on that one. But are they able to adequately oxygenate and ventilate? And then, is their mental status still stable? Did you put them on pressure support and now all of a sudden they're obtunded and unresponsive? Maybe because they're hypercapnic, right? Their mental status has to remain stable. And then, do they have a tolerable work of breathing? They're not diaphoretic, they're not using accessory muscles, they're not belly breathing, they're not super tachypnic, right? Do they have a tolerable and stable work of breathing is the other critical thing. And this is all very subjective to a degree. You're looking at the patient, you're like, what do they look like? How are they breathing? Do they look comfortable? Et cetera, et cetera. When we try to make this process more objective, one of the common markers people talk about is something called the Rapid Shallow Breathing Index, the RSBI. Some people call it the RSBI. And the Rapid Shallow Breathing Index is a math equation. It is the respiratory rate divided by the tidal volume in liters, okay? So respiratory rate divided by tidal volume in liters. And when people have studied this, if we think about what this means, it essentially means that they're breathing comfortably, so the respiratory rate is reasonably low, and that they're pulling high enough tidal volumes. Because you want the RSBI low. Less than 105 has been a good predictor of successful extubation. Now we'll go into the trial, one of the big trials on the RSBI, because it's not perfect, so you should always use it with your clinical judgment. It's not an end-all be-all, but it's maybe an easy place to start, especially for trainees or people early in the field who kind of want something more graspable to help them understand if a patient can be liberated. The RSBI is a reasonable place to start, but it's not the end-all be-all by any means. Okay, so respiratory rate divided by tidal volume in liters. So one of the newer trials on this was from 2016. I don't know how to pronounce their name, apologies, but Tanios et al. Published in Critical Care Medicine. And it was a prospective multi-center observational study. Okay, so this is not a randomized control trial. And it looked at the rapid shallow breathing index in ICUs. And it was after there was this trial in 1991 by Yang and Tobin, which was kind of the OG RSBI trial, that showed a really good sensitivity and predictive value of the RSBI. But then Tanios et al. Went and tried to see if they could validate this. And they looked at about 900 adult ICU patients. It was mixed medical, surgical, trauma, and neuro ICUs. They looked at all mechanically ventilated patients deemed ready for weaning, right? So the patients that met those other criteria: hemodynamic stability, oxygenating appropriately, ventilating appropriately, mental status improving, et cetera, et cetera. And the primary outcome was extubation success versus failure at 48 hours. So did they need to be re-intubated by the 48-hour mark? And they used the RSBI cutoff of less than 105. And the results here were that those who had an RSBI less than 105, still it was associated with a higher probability of extubation success, but it was fairly modest in terms of the results compared to the original 1991 trial. There are still many patients with an RSBI of less than 105 that failed extubation, and some patients with an RSBI of greater than 105 that had successful extubations. So all this to say, that this is one marker amongst many markers you should be thinking about when you're thinking about liberating a patient from mechanical ventilation. As we said, a good place to start, but not the end-all be-all. Do note that this was an observational trial. It was not randomized. They looked only at an RSBI less than 105, not like multiple different RSBIs. And there's some things you couldn't really account for: airway protection, secretion burden, all that kind of stuff, which obviously can affect extubation failures. So bottom line here, RSBI's maybe, a screening tool or just one piece of data, but its predictive accuracy is not absolute, and you should use your clinical judgment and some of these other kind of clinical assessment strategies in addition to the RSBI to help guide you. So with that being said, key considerations, signs of failure would be severe tachypnea, hypoxemia, tachycardia, hypertension or hypotension, agitation, diaphoresis, right? Anything that looks like there's increased work of breathing. Trial duration that we said is 30 to 120 minutes, variability there. Failure is usually declared earlier if there's intolerance. And the big thing here, and we probably should have said this earlier, is there is incredibly robust evidence that daily spontaneous breathing trials and sedation interruptions reduce ventilator days and improve mortality. So all patients, we cannot stress it enough, all patients that qualify should have daily SBTs, spontaneous breathing trials, and SATs, sedation vacations. Every single patient that improves mortality and reduces ventilator days. Absolutely it does. This should happen for all patients. All right, to end here, we'll have some practice questions, but we just put a table in here, and every one of these study guides will be on our Patreon page, which is in the video episode description. And we upload all of our study guides, practice questions, ad-free videos, med-ed posts, discussions, all that good stuff. So definitely check that out. We'd love for you to join or hop on board. But yeah, the study guide will be on there if you're interested in accessing the study guide, because this table here is kind of a comparison of spontaneous breathing trial methods, including the T-piece trial, pressure support trial, and CPAP trial. And just going with setup, right? For a T-piece trial, the patient's literally disconnected from the ventilator and hooked up to humidified oxygen. For the pressure support trial, the patient remains on an inspiratory pressure and a PEEP. And for a CPAP trial, the patient just remains on PEEP. So from a support standpoint, a T-piece trial, there's no support. There's no PEEP, no inspiratory pressure. For a pressure support trial, there's inspiratory support and PEEP. And then for a CPAP trial, there's just PEEP. There's no inspiratory support. So the physiology here for T-piece trial is, post-extubation conditions. People will say a T-piece trial is closest. We actually disagree with this because it doesn't account for the resistance of the endotracheal tube. For a pressure support trial, it accounts for tube resistance, so it's arguably the most realistic. And then for a CPAP trial, it just has PEEP. It's maybe like in the middle there somewhere. Advantages for T-piece trial, it's simple, no ventilators needed, but the patient was already on a ventilator, so is that a real advantage? Probably not. Pressure support trial, it's most commonly used, it's most comfortable for patients, it's easy monitoring, and there's the most evidence behind it. And then for a CPAP trial, you at least maintain alveolar recruitment and prevent atelectasis because they're on PEEP, although you don't provide any inspiratory pressure to get over that endotracheal tube resistance. Disadvantages for T-piece trial: increased work of breathing, overestimates failure, not supported by the evidence, requires disconnection from the ventilator. Disadvantages to a pressure support trial is, it may underestimate extubation difficulty because you do get a little inspiratory pressure support, although that theoretically, if it's low enough, should just be enough to get over the resistance of the endotracheal tube. And then CPAP trials, disadvantages are they're less well validated. People just haven't looked at them as much. Common use, we would say TP's trials, much less commonly used today. Pressure support trials, widely used. CPAP trials, not commonly used. And then evidence, there's most evidence supporting pressure support trials, much less evidence supporting CPAP or TP's trials. All right, let's get into some practice questions. If you have not participated in practice questions in one of our episodes before, the structures will read the question, we'll read the answer options, and then we actually just go right into the answer. So if you need more time to think about it, just pause the episode because we're going to jump right into the answer. So question 1, beginner, there will be 3 questions. Which of the following is the primary purpose of spontaneous breathing trial? A, to reduce sedation requirements. B, to evaluate readiness for extubation. C, to measure lung compliance, or D, to prevent ventilator-associated pneumonia? Pause here if you need to. The answer is B, to evaluate readiness for extubation, right? Every patient should be having a spontaneous breathing trial every day to determine if they might be ready for extubation. All right, question number 2, intermediate. A patient is on a pressure support of 5 centimeters of water, a PEEP of 5, an FiO2 of 40% during their spontaneous breathing trial. After 1 minute, their respiratory rate is 30 and their tidal volume is 300. What is their RSBI and does it suggest success or failure? So we'll do the math with you here. So RSBI, rapid shallow breathing index, equals respiratory rate divided by tidal volume in liters. This patient's respiratory rate was 30 and their tidal volume was 300 milliliters, which is going to be 0.3 liters. 30 divided by 0.3 hopefully is 120 maybe? Uh-oh. Did we do our math wrong? Good thing we have a calculator right next to us on our phones. 30 divided by 0.3 is 100. I actually think we might have done our math wrong for the answer. So it should be 100, which is B. Less than 105 is most likely success, but it's kind of right on the border. But did we put, yeah, we did. We put C, but that's not true. We just did our math wrong. Good thing we got to explore that together. So the correct answer is B, 100, which is borderline. It still meets, right? Less than 105 is that magic number that they used in these RSBI studies. But as we talked about many times, this is just a single data point. It shouldn't be totally dependent on. And then last question, question 3, advanced. In randomized controlled trials, which approach was shown to shorten time to extubation? A, intermittent mandatory ventilation weaning. B, pressure support ventilation with gradual reduction. C, daily SBTs with prompt extubation if tolerated. D, routine use of CPAP trials for 24 hours. Correct answer is B, daily SBTs with prompt extubation. This absolutely is the thing that you should all be focusing on in your ICUs. Give patients, gosh, we are striking out here. We circled the wrong answer on the video. Give patients daily SBTs, right? SBT, SAT for every patient, every single day that meets criteria, that improves outcomes. Absolutely, absolutely. All right, that's all we have for you today. Thanks for sticking around. Hope it was helpful. Check out our Patreon page, YouTube platform, podcast platform, all things emergency and critical care medicine. And either way, we appreciate y'all. Stay well and keep learning. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.